as a general principle for relapsed refractory myeloma, we take four components in making a decision how we approach such patients. One is the patient component. I mean, what's the patient age, what their performance status, lifestyles, patient preference, if they have any comorbidities like renal, which drug we need to have, renal toxicity, if they have peripheral neuropathy, which drug we could use because of that side effect. Again, cardiac issues. The other things we take into account is the disease biology itself, how quickly the relapse after the first line of treatment, what's the rate of the progression of the disease. Certainly, we use FISH for risk stratifications. We might consider, for instance, BCL2 inhibition for a patient who had 14 translocation. Certainly, treatment toxicity. So depend on patient tolerance, prior exposure, how much toxicity they have. We have a national cancer care program responsible for reimbursement of different drugs used in multiple myeloma, and will be guided what available, what license, what can be reimbursed through the national scheme. And the last thing we tend we use a triplet therapy from the regimen itself. We prefer to use a triplet therapy, but if we can't, we use a doublet therapy. Certainly, what previous treatment, how long the last response, what's the toxicity profile for the prior treatment. All of this will be taken in consideration when we're dealing with the relapsed patient. Certainly, for transplant eligible, we'll do transplant consolidation upfront. For any reason, if the transplant was not considered either due to maybe myeloma-related toxicity or organ dysfunction, but subsequently in the relapse setting, the limiting factor for the upfront transplant is not exist anymore, we might consider transplant in a second relapse. Certainly, I have transplanted for the second time patient who had a decent response for the first transplant. So if I have a younger patient who had the transplant, then he relapsed, then the response to the first transplant lasts maybe more than 3 or 4 years. A consideration for a second transplant will be to be considered. Now we have access to Daratumumab in relapse setting, and that will be monoclonal antibody treatment will be incorporated to different protocols to be used at relapse setting. So this is kind of the general approach for a patient who presented with the relapse disease. Yeah.